morning and happy Sabbath to you all. Um, my name is Toby Afolayan. I'm a cardiothoracic surgeon by training, but most of the work that I do is on thoracic surgical oncology. So I do a lot of work on any cancers that is in the chest, in the lungs, esophagus, chest wall, or things like that. Today we'll be talking about lung cancer and lung cancer in the community. I have a few Bible verses that I sort of consider thoracic surgery Bible verses. This is one of them. When I find myself doing something that has to do with cutting the ribs or things like that, I remember this Bible verse that says, "And the Lord God caused a deep sleep to fall on Adam, and he slept. And he took one of his ribs, closed up the flesh in its place. Then the rib which the Lord God had taken from the man, he made into a woman, and he brought her to the man." Why are we talking about lung cancer, and why we're talking about lung cancer in church? Lung cancer is the leading cause of cancer death in the United States. The most common reason why people die of cancer in the United States in 2024 is because of lung cancer. This is the statistic from 2023 for lung cancer. So if you think about the population of the United States, this is the number of new lung cancer cases in the United States. It's over 230,000. And the number of people that died last year of lung cancer is over 120,000 people. The graph on the right side is the demographic of the states in the United States. And the reason why this is important is that Texas, the state of Texas, probably at least since 2017, is the third leading state for lung cancer and lung cancer deaths in the United States. And if you look at the last point, if you took everyone that had breast cancer and died last year, and you took everyone that had prostate cancer, colon cancer, brain cancer, that died of all of those cancers, and you added them all together, that number is less than the number of people that died of lung cancer last year. So it's important that we talk about this and keep this in mind. The biggest risk factor, as we know, for lung cancer is smoking. And you might think in church a lot of people don't smoke, but one thing that's important to keep in mind is that the risk factor for smoking takes a while to shed off, over 15 years. And so if someone has smoked for a significant amount of time, it takes 15 years to see a dramatic decrease in their risk factor for lung cancer. There was a change in that 15-year number, and I'm going to talk about that in a little bit. People that have had other types of cancer are also at risk. People that have family history of lung cancer, especially in first-degree relatives, so parents, siblings, are at high risk of having lung cancer. People that have had asbestos exposure are at high risk of mesothelioma, but also of primary lung cancer. So 3 to 4% of primary lung cancers in the United States are from asbestos smoking exposure. People that work with beryllium and cadmium, so workplace exposure is a risk factor. People that have this disease called chronic obstructive pulmonary disease are at high risk of lung cancer. If you work around diesel fumes at your job with engines or truck driving, increases your risk. Coal smoke, and also radon. So what are some of the symptoms that are alarming? This slide is important, but it's also very deceiving. When patients present with these symptoms, it's a sign of a significant advanced lung cancer. So you want to try to catch lung cancer before people have these symptoms. So coughing up blood, being very, very, very short of breath, and that's not caused by anything else. Losing your voice constantly and persistently, so having hoarseness. A significant amount of weight loss without trying to lose weight. having swollen lymph nodes, especially in your neck and in your armpits, and then having chest wall or shoulder pain. All these are due to tumors that have caused some pushing or growing into nerves. It's important, this is one of the most important slides or most important things to talk about that people don't know. A lot of people know about lung cancer screening. In the United States, we know about breast cancer and women getting mammograms. We know about colon cancer, decreasing the risk, and men and women getting colonoscopies. But you can actually screen for lung cancer. And the way we screen for lung cancer is if you have anyone above the age of 50 who smoked over 20 pack years. The meaning of 20 pack years is you take the number of packs that someone smokes and you multiply by the number of years they've been smoking, regardless of whether they've tried a quit and had some small period of abstinence. If you multiply that together and that number gets to 20 or above, those patients qualify for low-dose screening. Over the years, this also applies to people who have smoked or have had that exposure or maybe quit smoking up to 15 years. However, in 2023, there was a change in this recommendation by the National Cancer Care Network. The quitting smoking at 15 years is now gone away. And that is because there are people who have over 20 pack year smoking history and quit smoking 20, 30 years ago that still remain at significantly elevated risk of smoking. Now, this is not caught up to the insurance companies yet, and so they will try not to pay for screening in someone that quit smoking over 15 years ago, but it is to your benefit to remain and continue to screen yourself for lung cancer, even if it's over 15 years ago. And so how do we do that? Patients get what is called a low-dose CT scan. A low-dose CT scan is a very quick, painless way to find out if someone has lung cancer. The radiation risk is very limited. It's equivalent to a few chest x-rays and several times less than a regular CT scan. This is something that we've known about for decades. Can anyone guess the percentage of people that qualify for CT screening in the United States that actually get screened? Just shout out a number. Less. So for several years, it was actually 3%. It's gone up a little bit. People think it's closer to 8% now, but that's sad. That's 8% of people that could have lung cancer that are not getting screened. So this is important. So if you know anybody that has smoked significantly, I tell people the easiest way is if you know someone that has smoked for over 10 years, you need to start doing the math, because for most people, it's probably close to 20 pack years. You need to push them. Family members, parents, brothers, sisters, you need to push them to go get screened for lung cancer. And this, this is covered by insurance, okay? It is 100% covered. So when you do low-dose screening CTs, you don't always catch cancer, you catch other things as well. Not all nodules require surgery right away or some intervention, but they need to be followed. The number that I always throw out to people is when nodules start getting to even 8 millimeters is starting to get on the bigger side. I think around 6 millimeters, it is important to start getting those nodules looked at closely. We now have technology that can biopsy lung nodules that are as small as 6 millimeters. Some small nodules can be monitored, but above 8 millimeters, we actually start biopsying them. The other reason why this is up here is because if you get a CT scan in the United States today and you have an 8 mm nodule, there's going to be a comment there that says you have 3 options: watch it, get a PET scan, or biopsy it. I want to caution you very, very careful at the first recommendation of watching it. I had a patient who was in his 40s in August who saw that and said, I'll just watch it. And 6 months later, the tumor doubled in size. So if it's over 8 mm, you should push someone to biopsy it. The people that manage lung cancer are oncologists, so medical doctors that give chemotherapy, pulmonologists, and someone like myself who's a dedicated thoracic surgeon that manages thoracic diseases. So this is a CT scan of someone that has lung cancer, okay? This is the chest, this is the right side of the patient, this is the left side, this is the front, this is the back. And the little white area of specks that you just saw go by you, it's gonna scroll backwards now, that's lung cancer, and that's what you caught, that's what the patient caught in the low-dose screening CT. This patient had nothing in their low-dose screening CT the year before. And what you just looked at is a 3 cm, after I took it out, it was a 4 cm tumor. So that's how fast some lung cancers can grow. So how do we find lung cancers, and what do we do when we see one that's concerning? We do some diagnosis and we try to stage them. This is a PET scan, it's another CT scan, but certain areas that absorb metabolic activities will light up, and it increases the chances that something is cancer or sometimes inflammation. So some patients need a brain MRI. There are certain patients who do either a regular bronchoscopy, which is using a camera to look at your airways, or we use a robotic bronchoscopy that allows us to get further down and actually biopsy the nodule. There are several ways to biopsy lung nodules. You can put patients to sleep and go from the inside, or you go from the outside. It's a relatively straightforward test. And then we also look at pulmonary function tests, which is how well your lung will do if we take out a part of your lung. So this is how we control most cancers, lung cancer included. You need to do a local control of the tumor and also a systemic control of the tumor. Not all patients need systemic control. It depends on how advanced the tumor is, but everyone needs local control. So most times we try to get patients to surgery. If they're not a candidate for surgery, we get them to radiation. But surgery by far is the most common way we control tumors. The reason we're having this talk also is this. Lung cancer is one of the cancers that's treatable. You can cure people of lung cancer. This is how we treat people surgically for lung cancer. This is a video from YouTube that I think explains this well. I don't know if we can get the volume up. Can't get the sound? Okay, so this is just an example of a patient that had lung cancer and was talking about it. There are 2 ways in which we do surgery for lung cancer. We do what video-assisted thoracoscopic surgery, and that's when you use a camera with your hands, and you make a small incision or some small incisions, and you cut out the tumor. The way I do mine is robotic, which is what you saw there. It's a technology that allows us to actually sit down and connect the patient to a robot. It has better definition of with a better 3D camera. So we use a 3D camera and some arms, and we control the robot to actually define and separate that area where the tumor is in the lung, and we take the tumor out. So this is video-assisted thoracoscopic surgery, just some instruments and a camera to take out the tumor. Um, a more modern way is to use a robot, which is what this is. This is the most common robot that's being used in the United States now. We sit down on the console, connect the robot to the patient, and then we separate that part of the lung out, and we take it out of a small incision. Most patients are home, in about 24 hours or sometimes 3 days, depending on a few other factors that might keep them in the hospital. The treatment of lung cancer, that's early stage. If you take out the lung tumor, we take out both the tumor and the lymph nodes around the area. If the lymph nodes have no cancer in them, the patient is completely cured, regardless of the size of the tumor. Most patients that are less than 3 centimeters, that have tumors less than 3 centimeters, don't require any chemotherapy after. We just follow them for recurrence. Most of those patients, over 96% of them are alive after 5 years. So the reason we screen patients is because you can cure them and you can catch cancer early. So that's why. This slide is important. This is the National Comprehensive Cancer